Welcome to North of 60. I'm Heidi Schweighofer. Today we're going to talk about two important tests that senior women need to be aware of: mammograms and bone density. And my guest is Sharon Martino, the Women's Health Manager from Western Reserve Hospital. Thank you, dear, for coming. I appreciate it.
Thank you for having me.
I want to talk, let's divide this up and talk about mammograms first and bone density second.
Okay.
So, mammograms. Tell me what the guiding principles are in a woman over 70. Every year? No? Every other year? Stop at a certain time? It's very confusing.
It is very confusing. In the last probably decade, there have been multiple agencies that have come out with differing data on that.
Okay.
To
Maybe
be honest.
That's why it's so confusing to
It
hear
is.
about
It's
it.
confusing for us to follow as well. The U.S. Task Force recommends every other year from age 70 to 74 with, that definitive cutoff.
So 74 being the cutoff. All right.
Per the U.S. Preventative Task Force.
All right.
Most imaging centers in Northeast Ohio follow the American College of Radiology recommendation, and that is yearly from 40 to 75.
Okay.
So there's that discrepancy between yearly, every other year. Both agencies mention that what you really want to follow is the guidelines and having conversation with your doctor, because women who are at a higher risk want to come in that every year.
Right.
Women who are at a lower risk may choose to do the every other year. However, it's a fact that our risk of developing breast cancer increases with every year that we're another year older.
Yes.
So that's why I think it is often so confusing and very contradictory,
I think
because
so too.
our risk factor does increase. Again, some of the more aggressive breast cancers happen in our younger years because of the hormone
Right.
fluctuations
I've read about them.
that we have going on in our bodies, right? But we still have an increased risk as we get older. So, in my opinion, in the American College of Radiology's opinion, our opinion at Western Reserve is talk to your doctor, talk about risk factors and know your risks. And we'll get into that here in another minute, because I do want to hit on that. But make sure, if you are healthy and active and getting out there and, going places and doing things, come on in and get your yearly mammogram. The idea behind mammography is still to catch a problem early. While it's so easy to take care of, we've come so far with surgical techniques and treatment, and our technology for imaging has gotten so much better with the 3D, the tomosynthesis. We're seeing things smaller and smaller, which means we catch them earlier. People need less aggressive forms of treatment. So, if you're healthy and active, keep coming. If you are developing other chronic illnesses and it's harder and harder for you to, get out and about, that's when you might start thinking about, is it time? Do I still need to come and get my mammogram every year? Would I do anything?
Well, that is the one question that I was asked, I think, at my last mammogram, and it was just a conversation I was having with the tech during the procedure, and she said, well, we just sort of ask women at a certain age, well, if you do have breast cancer, would you want to treat it? And I thought to myself, well, yes, for the foreseeable 20 years, yes, but maybe that's not everybody. Maybe if there's other things happening.
unfortunately, sometimes as we get older, people start having other conditions, congestive heart failure, emphysema, problems,
Ambulating, kidney.
exactly, mobility issues. And that's when you start to ask yourself, what would you do to treat this? Because sometimes treatments, even just surgery, can be traumatic on the body if you're having other health issues. So there's that to consider.
Sure.
But I still think it's an important conversation to have with your physician, and just your physician knows if you're, for example, a good surgical candidate or not. But I think to have a hard, fast age that applies to everyone is not really the answer.
I don't think it is either.
No.
Now, what I've heard is women's breasts get denser as they get older. Is that correct? And does that not change anything, but does that cause the imaging to be harder to read?
Actually, it's the opposite. So the younger we are, the more hormones are running through our bodies, right? The estrogen and the progesterone. That is what makes more dense breast tissue.
No kidding.
It doesn't make more dense breast tissue. Our breast tissue is defined, but when we're born.
Right.
Some women have fattier breasts. Some women have denser breasts, which just means they have more fibroglandular breast tissue. That's the milk ducts and milk glands that feed our babies. Okay? As hormone levels taper, those milk gland and milk ducts kind of start to recede a little bit. And you hear terms like fatty replaced in the breast. And that just means as our hormone levels taper, that glandular breast tissue can taper. That is also dependent on whether, your physician has you on hormone replacement therapy. Some women still
There's
take...
a lot of women I know in their 70s and 80s that are still taking that.
And that can maintain that glandular
No
breast
kidding.
tissue.
I never knew this, Sharon.
Yes.
So they would have a different image from those of us who don't take hormone, potentially. I mean, there would be more density because they're taking, no kidding. What about women who have had or have implants? I don't know, does that change? Does it make it harder to read the image?
So with implants, yes, a lot of breast tissue is obscured. Okay. However, we do, and when I say we at Western Reserve, but also we find we follow the standard national protocols, which is additional views for patients who've had augmentation. So we start out, to simplify it, doing the same 4 views we do on any patient who has not had augmentation. We do a top view and a side view of each breast. And we try and get all the way back to chest wall.
I know. It seems like you're grabbing the whole thing. Yeah.
Well, a lot of people don't realize it. It really, it's not just what we visibly see. But so we go through the motions of those 4 views. However, we don't compress on the breast. The compression paddle just comes and it just really rests on top of the breast.
Sure.
You can't compress that implant. Okay. Those images show the integrity of the wall of the implant. It really doesn't show their breast tissue, okay? But it's important to see the integrity of the wall of the implant. Then we go back, and there's a technique that was developed, 20, 30 years ago by a radiologist, Dr. Eklund. We call it the Eklund technique. It's also just called the displaced views. And we physically work the implant back against the chest wall as much as we can. And we manipulate the actual breast tissue forward, and we position and just compress on the patient's actual breast tissue.
Wow.
But that's important because
Sure.
compression, while we know everybody, doesn't love the compression, right? Compression is important for several reasons. It makes the test safer for you by reducing your radiation dose. And so
Oh.
women who have a concern about the radiation every year, compression reduces the radiation dose
Oh.
you receive. Compression holds you still, reduces image blur, which would
Right. That makes
mean I
perfect
would have to
sense.
take, more
Right,
more pictures
right.
without blur. It's not a lot different from regular photography, right? You don't want a blurry image,
Right.
headshot
Right.
or something. So it controls the blur. It's what helps separate, that fibroglandular, the milk glands and milk ducts
Right.
I was talking about. It helps separate that normal breast tissue that, and helps the radiologist look through that and look for those tiny little things that might be hiding in there. So compressing the tissue, the patient's actual breast tissue, away from the implant is what allows
Yeah.
us to see their actual breast tissue without the implant obscuring that.
All right.
So it's, a lot of people don't realize implants are very mobile. They're meant to move inside of us. And so, working that tissue away is not harmful in any
Yeah,
aspect.
okay.
And then, a lot of
I've
people
always
worry.
wondered this.
A lot of people worry about rupturing of the
Right.
implant, but
It's not in the
we
compression
don't,
thing.
We don't compress on that
Yeah.
implant at all.
I know some women my age who had implants because of previous breast cancer and a mastectomy. And I don't know a lot of, but who knows who's got what in
Yes.
them. So
Yes.
what I heard and read about false positives, I don't know whether it comes with age or whether it's just there's a standard false positive and one has to figure that out. I guess you'd be the one who'd have to figure it out, or the radiologist.
The radiologist.
Yeah.
But there is a false positive rate. I always tell people when you're coming in to have a screening mammogram, we call back about 25% of screening mammograms. Women coming with no symptoms, no problems, just for their yearly. But you have to remember, our goal is to find things as early as possible.
Right.
So they're looking for change from your last mammogram, and they're looking for the tiniest, most subtle changes that might be indicative of, something going on. However, and many women don't know this, there's many more benign processes in the female breast than malignant or cancer, fortunately. So we always err on the cautious side. We know it causes anxiety for women to be called back from a normal, screening
Yes.
test.
I had it happen once, and it's, oh my Lord.
It does cause a lot of anxiety. I try and tell all my screening patients, it's not an immediate red flag. It just means we need a little bit more information about this area,
Okay.
And sometimes we take additional mammography images. We can do breast ultrasound, but we're going to do whatever we need to do to determine if that area still looks concerning enough to warrant a biopsy, or if the area has all benign characteristics and it's nothing to worry about.
Sharon, you brought up something. I know we were going to talk about it a bit later, but I want to talk about comparisons. So if I go to Summa and then Cleveland Clinic and then you, do you want what I had at Summa Cleveland Clinic before I get to you, or during? Is that important for you and your radiologist?
So comparison is always very, very important. However, you don't have to track them down and bring them. Some patients do. Some patients will call the facility where they were at last and orchestrate that. However, when you're coming for the screening, we will request them for you. Once you arrive for your appointment,
good.
we have a release form. We do need your signature because of HIPAA and privacy,
right.
but we will fax the facility and
Oh,
wait for those
good.
previous to come in. You know, we make sure the patient knows their report's going to be delayed a little bit to their physician. But that's how important comparison is, because, you know, every year we're another year older, our bodies change,
Yep.
but not all change is bad. You know, but again, the radiologist wants to look for change, catch early change,
Right.
investigate it if need be, make sure it's nothing to worry about, or if it is something to worry about, get it handled and taken care of so women can go on and live long, healthy lives. So comparison, at least if I could stress one thing to your viewers, a lot of times women come in and say, you know, I don't remember where my last mammogram was. Try and think about it. It's it's important. You have a better guess than I do where your last mammogram was, but you know, we've learned how to be pretty good detectives, and even when people are out of state, you know, or have come from out of state, we have a directory, a book that lists every accredited mammography facility in the United States. And I'll often say, oh, your last one was in West Palm Beach. Well, was it on, you know, Cleveland Maslin Road, or was it on Canton Road? And they'll be like, oh my gosh, you know, I remember I drove right there, and then we can get them and request them, and
Good.
So it's not, you know, a hard stop if we don't have comparison, but it really can make a big difference on whether you get that callback that causes the anxiety. It can make a difference whether you need a biopsy or not.
Yep.
But back to the false positives, they're going to err on the cautious side. If they have this much doubt, they're going to ask you to come back, whether they have the comparison or not, you know, just to
That's good. That's
be
what
thorough.
I would rather. I think everybody would rather have that happen.
And when we explain it that way, I think it helps women with that anxiety of getting called back, you know, and you know, I've seen that change in people, and they're less anxious coming back, because it's just, you know,
it happens.
It happens, and it's just, you know, maybe a little additional testing and everything's okay.
We are going to switch to bone density.
Okay.
I want to do one last question about mammography, maybe about breast health. What factors right now should I be paying attention to at age 70 for optimum breast health until I'm 100?
If you are on hormone replacement therapy, talk to your doctor about that.
Okay.
See if you should continue.
Okay. That's one. What
There's
about diet?
Diet,
Are there any,
you know,
I've read meat eating.
a lot of red meat, excessive alcohol, you know, but then you read about the benefits of red wine. So I think if you consider everything in moderation, the environmental factors within our control are taking hormones, hormone replacement, you know, diet and exercise. Weight, being very overweight can increase your risk of cancers in general, not just breast cancer.
Right.
So keeping a healthier weight, and, you know, everybody's talking about plant-based diets, right? So, and for a lot of reasons, I think the biggest factor is keeping inflammation down, and they're learning more and more about inflammation being the cause of what causes cells to mutate, to become cancer cells. just like the viruses.
Right.
Those cause inflammation in the body,
Right.
and then create these different symptoms and
All right.
diseases.
Healthy lifestyle, basically, in keeping one's weight and within a normal limit.
Yes.
All right.
Yes.
Bone density. I read DEXA, D-E-X-A. What is that?
I mean, that just stands, and I have to refer to notes because,
Oh, it's
I
not
don't-
that big of a deal then.
Well, I mean, what it technically DEXA stands for in the imaging world is dual X-ray
Oh,
absorption,
is
absorbatory.
it a number? Is that the machine or a number?
So, if I may, let me back up and explain to you the test like you're about to have a bone density test.
Excellent.
So what I tell everyone, the bone density unit, the actual imaging unit that we use, has software that we plug information into. And so I am going to plug in your exact height, weight, age. It calculates your age to the day, so many months and days.
Really?
It
All
does. Ethnicity, and then other factors. So this algorithm spits out a number, and it says where your bone density should be for you. Because a normal part of aging is bone loss, okay? However, environmental factors, diet, exercise, chronic illnesses, medications for those chronic illnesses, all can affect and accelerate that bone loss.
Okay.
So the machine is first based on medical and family history, is going to tell us where you should be.
Okay.
And then we scan through two body parts. We scan through the lower spine and one or the other hips. The reason we choose those two body parts, those are our largest, hardest, densest bones. And, a lot of people will say, but my neck hurts or my shoulder hurts. Can you scan through? That's not what this test is for. Chronic joint pain, arthritis, those are regular x-rays. This bone density test is just checking how hard or soft our bones have gotten over time. So again, we know where you should be, and then we scan through the two body parts, and the machine averages those two, and it says where your bone density is. Now, if you're, of course, here or better, everybody's happy. If you're trending down and you have more bone loss than is age appropriate because of whatever factors,
Right.
that's the information in the report that's going to go to your doctor. And then that starts a conversation about, if it's just a little bit of a difference, there's things like modifying diet and exercise. So a couple things that deplete our bones are caffeine in excess.
No kidding.
Back in the day, some of our mothers and aunts might have, sat around the breakfast table and drank a pot and a half of coffee while they're smoking their cigarettes, having a morning conversation,
Nice,
right?
healthy way to start the day.
Nicotine and caffeine deplete our bones. Okay, so
I knew nicotine did.
Yeah.
I never knew caffeine did.
Yeah.
Okay.
then you have some of these medicines that people take.
Prednisone. Yeah.
Steroids.
Yeah.
And a lot of people say, oh, I've never taken steroids. But if you have asthma, if you have exercise-induced asthma, if you have emphysema, if you ever have used an inhaler, those have,
Then it's.
many of those have
And I don't
steroids.
think people would automatically think that.
Correct.
Okay.
Those have steroids in them. Now, I fortunately don't have asthma. I can't imagine, gasping for breath. I'm not going to say, well, I better not use my inhaler because it's going to deplete my bones. I mean, some of this is necessary and it's a part of our lives, and they're valid treatments for a lot of these chronic illnesses. I don't want to give the impression that we're saying don't do this. Just throw your inhaler away or whatever.
Well, let me ask you this. It seems like all of a sudden I know of close friends and women my age who have had their first bone density test, late 60s, early 70s, and find out that they have osteopenia. One of the women is extraordinarily thin, and the other had a mother who had osteoporosis and had fractured a femur and all of this stuff in her late years. So does thinness, that sounds dumb, does thinness impact it? Is there a genetic predisposition? Does one know?
So they've not come out and said there's a genetic predisposition, but a lot of it is based on, and I don't know if thinness is a good word, but I would use it because we do find that smaller ladies, but a lot of that has to do with, think of what their bony skeleton is like, okay? My mother was 4'8", tiny little Italian lady, tiny. I mean, she had terrible osteoporosis. She might have been one of those ladies that sat around the coffee table drinking her coffee all day long, and but so it's kind of more like your frame. So a smaller framed lady, and they tend to be those small, thin women often, not to say, but in general, kind of stereotyping, smaller framed women tend to, because they don't have a lot of bone mass to begin with.
Oh, that makes perfect sense.
Remember this trick back in the day?
Oh, yeah. Oh, God, yes.
Cosmo magazines would say, okay, put your thumb in and see if you're small framed, medium, or large. So, if you think about it that way, then it makes perfect sense. Smaller framed, smaller boned, shorter, thinner, any of that can fall into that category where their risk of osteopenia and osteoporosis are higher because they didn't start out with
a lot of bone to begin with. Yeah. If it's okay with you, we're going to run over a little bit and keep talking.
Okay.
Diet. What are environmental factors I can control to either increase, if that's possible? Can I increase my bone density at age 70, or at least keep it the same way? Should I be gulping down calcium supplements, which I don't know why I don't like them, but I don't like them, or should I be, weight bearing, and what should I be doing?
Recent information has come out that one of the best things you can do for your body is weight training, and a lot of people focus on cardio after a certain age.
That's right,
because we want to keep our heart healthy. But true weight-bearing exercise is every bit, if not more important than cardio exercise, to maintain muscle mass, which then maintains bone mass. So they say that
literally weight training, or
so a lot of women then get in their mind, I've got to go to the gym and I've got to start lifting weights. The machines that have resistance, even the bands, those resistant
we use those
bands,
a lot in the exercise class.
That is technically weight training because it's causing resistance. Okay. So there's many different types of weight training that you can do. But it's not just getting out there and power walking, you know, for an hour and a half every day. While that's still very important, you know, I don't want to take away from the health benefits for good cardio, but weight and strength training is very important as we age. They say that women after age 30 that we start losing bone mass and muscle mass.
Isn't that impossible to believe? But I can, you know, I can understand that.
Yeah.
I think that we do stop.
Yeah.
We think everything is the walk.
Yeah.
The walk.
The walk. Yeah.
And I love walking.
Yeah.
But everything maybe isn't the walk.
Yeah. And the other thing that's important, and I think many women, I know I pay attention to this as I'm getting older, you know, we watch our protein, but protein is what muscle and bone need to stay strong and to rebuild itself. You asked me if if a woman can do anything to increase her bone density. There are some new medications out there that.
Oh, I've seen them on TV.
Yes. Can you gain back what you might have lost in weight? And I don't think so. But you know, maintaining what you have is still very important.
So Sharon, if you have osteopenia,
Yes.
and you do take the medication perhaps that your doctor prescribes, you do the right things. You start doing some resistant bands, you keep your walking up, you keep your weight down, you know, all of the good things. Can you stay kind of at a steady course right on through your life?
Absolutely.
Oh, that's good to know.
Absolutely.
It doesn't have to be downhill.
It doesn't have to, you know, you can get to, you know, your numbers may be in the osteopenia level on the chart, but, you know, anywhere you can stop the
Progression.
or decline,
Yeah, decline, yeah.
you know, the better off.
All right.
Yeah.
How often should I be taking, I have had 2 in my life, and I'll be 70 this summer. I had one at 60 something and one at 60 something. I think one foot, one, an ankle.
Oh, yes.
And
the
then one,
heel.
then a hip.
Okay. So again, guidelines that a lot of primary care physicians follow is the, just like there's an American College of Radiology, there's an American College of Family Practice Medicine. And they, as a generalized statement, say that women under 65 don't really need a bone density test.
Oh, well,
However,
my doctor thought it was important.
it's a little bit like the mammogram
Right,
controversy.
right.
You have to have a conversation with your physician.
Right.
You have to find out, am I at risk for osteopenia?
Right.
Am I a small framed female? Did I have early surgical menopause? You know, did they have a complete hysterectomy
Right.
at 38?
Right.
And so the estrogen that my ovaries would have normally made and kept my bones strong, you know,
Right.
do I have asthma and have I been using an inhaler for the last many, you know, if any of that factors into your, you know, past, these physicians need to order bone densities much earlier than 65.
That makes perfect
65 is
sense to
just
me.
a very generalized age, but
Do I need one? Mine was normal. Do I need one again at 80 or 75?
so they say to have them every 5 years if
Oh.
you're in a normal range.
Okay.
But if you're osteopenic or osteoporotic, then your doctor would order one more often and
Okay.
hopefully be offering you treatments, whether it's prescription treatments or just the suggestions of diet, exercise,
And weight training, yeah.
you know, but they'd want to monitor you in a shorter period of time
Right.
to see if you're halting the decline and maintaining, you know, or you're continuing to decline, and then maybe that course of treatment isn't satisfactory and we have to look at something else, which may resort to prescription medication.
Last dumb question. Should I be drinking milk? I don't particularly like it. Should I be drinking a glass of milk every day?
You know, whatever way you can get some calcium.
I get through leafy vegetables. You can get but you're making the face like, yeah, I should probably.
I mean, we
drink a
do
glass of
ask,
milk.
but I remind,
Yeah.
and most women, I don't know what it is about milk, but and this is my personal presumption. It's not based on any fact, but it seems like us women just don't like to drink milk. So I remind people, but yogurt is a great source of calcium.
Yeah,
and
good,
cheese.
Good.
I mean,
Yeah.
I don't know if we can be
I'm kind
friends
of a
if you don't like
cheesehead.
cheese,
I know,
right?
Yeah, I know. Yeah, I got
so
that.
there's other,
Yeah,
you know,
that's
so
true.
one of our
yogurt,
questions, do you think you get 3 to 5 servings of calcium a week, not a day?
Oh.
I saw your eyes go, and a lot of people are
Okay.
like, not in a day, but in a week.
3 to 5. I am writing that
servings
down.
of dairy is
Per week.
important.
Well,
Some people can't take calcium supplements. They cause kidney stones in some people. You know, there's a lot of reasons. Some people, it makes them sick.
That is I never did well, except
Yeah.
those chews. I don't even know if they still make
yeah.
them anymore, but people have liked those.
Mm-hmm.
All right, we are over our time. Give our seniors one statement about mammograms and one statement about bone density that you think every woman over 65 should know. That's hard to do, I know.
It is. I'm trying to think of the most important things. With mammography, one thing we didn't even talk about was, you know, the fact that we know it's no one's most fun thing to do. Women don't like mammography. They don't like the compression. Technology has made so many advancements. We have new curved paddles.
That's what I heard. So that would be a little more comfortable.
Yes. I mean, it's still, you know, I do have women come in and say, well, I hear you have the new 3D, and my doctor said it's not at all like it used to be, you know, and I'm like, oh no, it's still the same. I mean, the positioning is the same, the compression, but we talked earlier why those are so very important. We don't want to miss anything going on in there. Makes the test safer. So if you've had a bad experience in the past, please reconsider. It's better.
All right.
So as long as you're healthy, active, talk to your doctor. You know, if they won't give you an order or recommend that you get a mammogram, talk to them and say, you know, I still feel like this is an important part of my overall health is my breast health, and I want to keep getting a mammogram and keep going. And as far as your bone density goes, kind of same thing. The last thing, as an active woman, living your life, living your best life. We should all be living our best life from 70 to 74 if we can, right? The last thing you want to do is step off of a step or a curb
and break something big.
Because, your bones are brittle and you didn't really even know. So have a conversation with your doctor about when, for you, it's appropriate to start having bone density screenings.
Sharon, thank you so much. This has just been really
Heidi.
Enlightening. And I when the show is done, we'll talk about my visit to you coming up, because I get mine every summer. So, but I also think what we'll do is put your information at the very end of this show. So thank you so much for watching. Sharon's information and how to reach the Women's Health, is that the name of the Women's Health area at Western Reserve Hospital, will be located at the very end of this show. So you can write down a phone number and give them a call. Thank you so much for watching. Bye-bye.
Thank you.